Dan Palazuelos is a global health implementer, educator, and practicing physician. He splits his time between clinical work at Brigham and Women's Hospital, medical education, and mentoring at Harvard Medical School, and implementation work at the non-governmental organizations Partners in Health. Please join me in welcoming Daniel.
Hi, everybody. Thanks so much for being here. It's my pleasure to come and talk about an issue that I'm very passionate about, which is helping to create the next generation of change agents, yourselves, that will make the world a better place. I'm an educator at Harvard and the Brigham, and I work with Partners in Health as an implementer, and I get a lot of young trainees come to me saying, how can I have your job? How can I do all the good that I want to do in the world? And we talk about the logistics of that, but then we also have to talk about some of the logistics of their own lives. So what I hope to do with you right now in these next 20 minutes is to go through my top 3 rules for career development in global health equity. So we did a study at the Brigham of the first 7 years of the graduates of our program, where we asked them what was their career development experience upon graduation. And we got nearly 30 respondents. We had these in-depth interviews with them, and we found that up to 80% said that they had a career that they considered to be including global health equity. But they also described a lot of challenges. And I want to focus on those because perhaps they will be illustrative for your own planning. This quote, I think, says it pretty well. And this was from one of our graduates. From my standpoint, the primary weaknesses of global health as a career choice is that there are not well-defined career pathways, which means that you have to go your own way, which is fraught with risk, financial and professional risk. And related to that, I feel like it is very hard to find strong mentors who can give good advice for navigating the uncertainties of that pathway. How many people feel like that talks to you? Lots of hands. It's a wave of hands. That's a problem, right? This was said 4 or 5 years ago. Why is that still the case? What are we doing wrong? Now, in this same issue of the Journal of the Graduate Medical Education, there was another article written by Nathan Thielman, who talks in an editorial about this very phenomenon, that it's not unique to the Brigham. This actually is being experienced across the field. And he asks, these are highly motivated, inspired, and often inspiring individuals who are a joy to mentor and to coach, but how do we help them navigate early career transitions, institutional expectations, and family obligations? How indeed? Now, he was talking about things that academic medicine needs to do to help people. I want to talk a little bit more on, in the meantime, while they're catching up to figure out that you guys are the future if we give you a chance, what can you do as individuals as you're preparing for this reality? Now, mind you, I'm going to be talking about global health career development through academic medicine in the medical route. That's not everyone in the room. That will be a bunch of you. That's also generally for people who are trained in the United States. Now, mind you, even though that limits the pool, and I think won't speak to everybody, I think there are some similarities here which I think are relevant, so don't walk out quite yet. I want to talk to you through this graphic about something that is often not described: financial compensation and effort. Now, I'm also going to be describing 2 main career pathways, comparing and contrasting. One is the idealized traditional academic career, and the other one is the academic expat global health career. So, the idealized traditional academic career was built around the time of Oslo. And people who work in this career pathway exert a considerable amount of effort, along with our colleagues in the expat career. But because this system was built 100 years ago to work through the system as we currently know it, the idea behind it is something called the triple threat. Perhaps you've heard that term. That's a physician that works in clinical care, research, and training. And back in the day of Osler, that made a lot of sense, right? Because medical care was just rounding. Research was describing the diseases you saw in your patients. And teaching was pimping a couple of medical students. Pimping is where you ask them obnoxious questions and make them feel very uncomfortable. It's not that game anymore, right? Medical care is incredibly difficult. There's an EMR, each patient brings reams and reams of information, there's multiple studies, it's a full-time job. Research, getting NIH money, maintaining a lab, trying to do work in implementation science abroad, it's also a full-time job. And education itself, my own medical school, Harvard Medical School, just went through this whole revamping of their curriculum to try and improve the educational experience. The place has been around for hundreds of years, they still haven't figured it out. Right? And so they're working on it. And that's in itself an incredible amount of work. So what people often do is they break up their time into a minority and majority effort. Usually you are in residency, that's after medical school, you're doing your training, and you might be working towards a T grant. That's like a trainer grant, a low-level NIH grant. This is the traditional pathway. Then you do fellowship, you might get a K under somebody else's R. R is where you want to be. That's the big grant where, your own academic institution will get 70% overhead, and you can build your lab, your research protocol, and then now you're a valued member of the academic community. When you get your R, you leave fellowship, your lab is fully established, and you get your R, that minority-majority flips. And you spend the minority of your time on clinical activities, 20%, 25%, and the majority of your time on the research, but then some other people put in some training, they put in some administration duties to be a good citizen for your group, and that's the way it works. Now, what do our colleagues and my trainees in academic expat global health careers? Now, mind you, I say here expat because that means that you're trying to spend a lot of your time abroad. What do they do? Well, they're also in a split, and the way that their split can be quite variable. But notice here that although the effort is the same, there's this gap between what they're doing with their clinical activities and their global health activities and their income. And this gap is what we call the global health tax. Now, we wanted to be provocative when we chose the term, and that's why we call it the global health tax. That's not a commentary on taxes. I actually love paying taxes. I do. Taxes are the thing that we pay to make society a better place. I live in Massachusetts. Now, mind you, this is not a tax in the traditional sense where we make money and then we pay it forward. It's more something that we experience in lost earning potential. So my first question, whenever I have a young trainee that comes to talk to me and say, I want to have a career in global health, I say, can you take a pay cut? Number one question, can you take a pay cut? Now what does that mean? It's a little rude. It means, can you pay off your loans? Can you take care of your family? Do you have responsibilities to cover? If that's the case, then this can be difficult. This is also true, by the way, for all the medical subspecialties or specialties that have lower reimbursement. For example, pediatrics, infectious disease, primary care in some sectors. It seems, unfortunately in our current reality, that pro-social activity is under-reimbursed. Now, you could be a surgeon, have a procedure, and do pro-social work, but that's a different story here. Can you take a pay cut? That's the number one most important question. And it's an important question because it's not about whether or not you want a fancy house in the suburbs. That's part of it. But it's also because this decreased earning potential actually sets up a difficult situation in the future if you're affected by something that we call the wild cards. So the wild cards are factors that are set up to challenge any career, but are particularly damaging to a global health career because of the logistical challenges of traveling, getting exposed to pathogens, decreased earning potential, responsibilities that might pull you back to the United States. Like, for example, you have a child with special needs. Can they have those special needs met abroad? You have, another situation with your family, and you have to be at their bedside when they're going through a terrible illness. So the second question that I asked people after I asked them about their earning, about their ability to take a pay cut is, tell me about your love life. And at that point, they look at me like they want to punch me. But I say, no, I'm serious. Don't tell me about your love life. But I want to tell you, rather, that you have to be very conscious about who you build in your family. If you marry somebody that wants to be a lawyer in Boston and has to be in Boston full time, it can get very challenging when you're traveling 6 months a year. So we say this ahead of time. A lot of people aren't married yet, and some people say, well, I can't choose who I fall in love with. Love is, love doesn't have a brain, it has only a heart. And I said, that is true, but the brain can prepare the playing field, right? So what does that mean? You're right now at a fantastic global health conference. Look to the left of you, look to the right of you, marry one of those people. I always like to say that because I imagine tonight's going to be a very romantic night for people at this conference. But I'm being serious though, because in all of our trainees, I have seen that the number one thing that takes them out of the game is when they have a moment with their family that makes it very challenging for them to be in it long term. And so to get to the final third point that I often make with our young trainees is, I'm going to go to this other article that was in this same JGME issue. And it talks about what employers look for in hiring new people. And then how can that inform Global Health Fellowship curriculum? And what they found, they found a number of different things. It was a very good study, but one of the things that was most illustrative was that they said most publicly advertised global health positions required previous experience and involvement in global health activities beyond clinical work. Now, this is the final rule for a fantastic career in global health. Once you have figured out the logistical challenges I just went through. It's that famous old joke, 90% of success is showing up. So what does showing up mean? Well, they're looking for people that have minimum 1 to 5 years, but really, most of the applicants, 6 to 10, greater than 10. How do you get greater than 10 years to get a job that gives you experience in global health? You do it through grit. Grit is passion and perseverance for long-term goals. I would say a lot of you are just starting off in your career. Choose something. Stick with it. Keep going. You're going to hit a lot of rough patches. Stay in the game. I myself, when I started off my current phase of my global health career in rural Mexico, and on the panel this morning I described some of those challenges. Because I was married to someone who was also working with me in global health, or rather, sometimes I was working with her, and we had aligned our family to understand what we were doing and that we were going to be abroad for a large part of the year. When we hit a hard challenge, we could support each other. I remember some very difficult nights under the stars in rural Chiapas saying, where are we going? What are we doing? But we support each other and we stayed in the game. And now we can point to successes, but 90% of success is showing up. And keep showing up. So, I'll close up with a final thought that perhaps will be also temper a little bit of this, if it sounds like it's a whole lot to chew on. This is not going to be true for all of your career. Your career is going to have many different phases, and that's okay. There's going to be a phase where you have undergraduate work, medical training, field work, you're meeting a partner, you have a young child, then later in your career. And you have these options of domestic work and work abroad. And, we often say that there is really good domestic global health work. Working in a federally qualified health center is fantastic domestic global health work. Working on Navajo Nation or other Indian Health Service programs, that is also fantastic global health work. And mind you, a lot of times better reimbursed than working abroad. In order to do this, you have to accept that sometimes you're going to have periods in your early career where you're abroad a lot, then maybe with a young partner, meeting your partner and your child, you're going to be home more, and then later in your career, you go more abroad. I actually see this is a stylized pathway. Not everyone will follow this pathway directly, but this is what I often see in a lot of our trainees. What I want to see is that it ends up with good, substantive efforts in equity. Global health is not about going abroad. Yes, it might include that, but global health is about dedicating yourself and your passion and your perseverance to equity long term. And I'm in the game to help you guys think through how can you align the pieces so that you can have your full heart, mind, body, and soul in the game long term. Thank you.
Thank you, Daniel.